Hello. హలో ఆడియో వస్తుందా? కట్ చేస్తా. హలో.
యా వస్తుంది ఆడియో.
ఓకే ఓకే సరే సరే.
స్టార్ట్ చేసేద్దామా 8:05 అయిపోయింది.
ఎంతమంది వచ్చారు?
ఎవరెవరు జాయిన్ అవుతారు అలాగే.
ఒక్క 2 minutes ఆగుదాము.
ఓకే.
ఓకే సార్, స్టార్ట్ చేస్తా.
ఓకే. ఓకే.
Yeah, so good morning, everyone. So today we'll be discussing on perioperative acute kidney injury. So the term acute kidney injury, it is used to describe a rapid deterioration of renal function, which can range from even hours to even days. So this rapid deterioration, it leads to accumulation of plasma waste products like urea and creatinine. And acute kidney injury, it is not an uncommon disorder and is associated with considerable morbidity and mortality. So the definition of AKI, it has changed and evolved over the years, making the comparison of incidence and prevalence among various studies very difficult. Even then, it is estimated that around 2 to 18% of all hospital inpatients, they acquire AKI. And the incidence of AKI is around 22 to 57% in ICU patients. And unlike the traditional belief that patients who recover from AKI, they usually return to their baseline renal function, recent articles, they show that AKI is a significant risk factor for even CKD. So it is also, AKI also induces further organ damage, which also contributes to more morbidity and mortality. So perioperative AKI, it is associated with increased risk of sepsis, anemia, coagulopathy, and even mechanical ventilation. So, in a prospective study of around conducted on around 1,200 patients having non-cardiac and non-vascular surgery, AKI was associated with increasing like morbidity and mortality. And we'll discuss these studies later. And a study investigating patients after general surgery, they reported an 8-fold increase in mortality in patients who had perioperative AKI. And a more recent large-scale study of patients undergoing intra-abdominal surgery, they found out that non-AKI patients had a 30-day mortality of 1.9% compared with around 31% in patients who had AKI. So as you can see, mortality is higher in patients with perioperative AKI even after complete renal recovery. So in this class, we'll discuss the definitions of AKI, the pathophysiology of AKI in relevance to the perioperative period, and specific considerations that are of special relevance, especially in the surgical patient. Coming to the definitions of AKI, the term acute renal failure, it appeared for the first time in 1951. And since then, many definitions have been used by the clinicians, which resulted in a lack of clarity among all the studies. And a review of different classification systems, it found out more than 35 definitions of acute renal failure. So these definitions, they all attempted to describe diverse aspects of the AKI. And given that a 24-hour urine creatinine clearance test is not straightforward to apply in everyday clinical practice, creatinine change from baseline is considered as a reasonable substitute and is roughly correlated with the change in GFR. So most definitions, they use urine output and creatinine as markers of renal function because they are unique to the kidney and are easily measured. So the first publication of consensus criteria for AKI, it was published in 2004. It is called the rifle criteria, that is risk, injury, failure, loss of kidney function, and end-stage renal failure. And it used serum creatinine or urine output to define the AKI. But in 2004, the term AKI was proposed as a replacement for the former term, that is acute renal failure. This change of terms, it highlighted the fact that loss of function and failure are preceded by a structural and physiological injury to the kidney. And later in 2007, a modified definition of the rifle criteria was published by the AKIN network, that is Acute Kidney Injury Network. Although the AKIN criteria evolved from the rifle criteria, a major advance was that even small changes in creatinine concentrations are associated with increased morbidity and mortality. The AKIN criteria, it allowed the definition of AKI even without the knowledge of baseline creatinine. So several studies, they were conducted on postoperative AKI, attempted to compare the predictive value of the two methods. And both the schemes predict the outcome of AKI with different sensitivity and specificity. This comparison, it also highlighted the need to select the baseline creatinine carefully when the diagnosis of AKI is based solely on the net serum creatinine change. So if the selected baseline creatinine is the first postoperative serum creatinine or the creatinine after fluid resuscitation, overdiagnosis of the AKI can occur. So in 2012, a clinical practice guideline of AKI, it was proposed by the Kidney Disease Improving Global Outcomes Foundation. So this guideline, it includes a comprehensive review of AKI definition, risk assessment, diagnosis, prevention, treatment, and even renal replacement therapy. So this group accepted the existing rifle and the AKIN criteria for the definition of AKI, and it proposed a simple practical criteria of AKI. So this criteria, it includes both relative and an absolute change of creatinine and accepts a short, that is 48 hours, and an extended time frame, that is 7 days, for the diagnosis of AKI. And the urine output criteria, it remained practically unchanged. So tabulating all of these criteria, we'll go through the this Kidney Disease Improving Global Outcomes Foundation definition. The stage 1 is increased serum creatinine value of around 1.5 to 1.9 times that is known or presumed to have occurred within the last 7 days, or an absolute creatinine increase of more than 0.3 mg per deciliter within the last 48 hours, or urine output of less than 0.5 ml per kg per hour for 6 to 12 hours is stage 1. And stage 2 is serum creatinine into 2 to 2.9 times, or urine output of less than 0.5 ml per kg per hour for more than 12 hours. And stage 3 is thrice of serum creatinine, or an absolute change of serum creatinine more than 4 mg per deciliter, or if the patient has been started on renal replacement therapy, or GFR decreases to less than 35 ml per minute in patients less than 18 years old, or urine output of less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours. So, despite the continued effort to standardize the definition of AKI using creatinine, these methods have several flaws. Like the increase in creatinine in the is it is usually late in the course of AKI, such that by the time the diagnosis is made using standard lab methods, the disease is already well established. And the change in serum creatinine, it can also be influenced by volume overload or nutrition, or if the patient is on steroids, or even in muscle trauma. So, and also a major issue concerning the AKI criteria is their relevance to the perioperative period. Like many surgical patients, they arrive in the hospital without a preoperative creatinine level. So, as mentioned above, this can lead to the overdiagnosis of AKI. And on the contrary, when patients do arrive with a pre-op creatinine concentration, the opposite can occur, because in the immediate post-op period, creatinine concentrations can be lower than the baseline because of hemodilution after massive fluid administration and fluid shifts. So comparing these post-operative and pre-operative values can lead to underdiagnosis of AKI and consequently delay the treatment. And also a major criteria is whether or not intraoperative urine output is reliable as a criterion for AKI. So we'll discuss that later. And recently, so major advances have been suggested that biomarkers might help to detect AKI early, identify the etiology, predict outcome, and even they can tailor specific therapies. So biomarkers are molecules that report on renal function or damage that relate specifically to different biological functions of the kidney. So for example, N-acetyl beta D glucose aminidase in the urine, it is a direct marker of lysosomal injury in the proximal tubule, whereas cystatin C in the urine is a marker of the reduced uptake by damaged proximal tubules. So some other promising biomarkers are kidney injury molecule 1, microalbumin, neutrophil gelatinase associated lipocalin, interleukin 18, and liver fatty acid binding protein. So a promising study conducted in the ICU showed that the combined use of two novel biomarkers, insulin-like growth factor binding protein 7 and tissue inhibitor of metalloproteinases 2, was a sensitive and fast way to detect AKI. A similar study, it showed that insulin-like growth factor binding protein 7 and tissue inhibitor of metalloproteinases 2 can also be used for the detection of post-cardiac surgery AKI. So several issues remain to be solved before these biomarkers can be used in clinical practice. For example, should biomarkers be normalized to urinary creatinine concentrations? What is their sensitivity and what is their specificity? And can we accurately define the sensitivity and specificity when making comparisons with a rather imperfect gold standard such as a serum creatinine? Or should a single biomarker or a combination of several can be used? So all these issues, they need to be solved before we can use the biomarkers in the clinical practice. So coming to the mechanisms of perioperative AKI, so the causes of AKI were traditionally divided into pre-renal, intrinsic, and post-renal, which provides a convenient classification. But the disease, it does not always strictly obey these definitions. For example, if pre-renal AKI, if it is profound, it can it can be prolonged and will eventually lead to intrinsic AKI or secondary AKI. So intrinsic AKI is better understood when divided into the major structures of the kidney, like damage to the renal vasculature from embolic events and vasculitis, such as malignant hypertension and hemolytic uremic syndrome, damage to the renal interstitium from allergic reactions, leukemia, lymphoma, and even bacterial infections, tubular damage because of secondary AKI, inflammation, exogenous toxins like contrast dye and antibiotics, and endogenous toxins like myoglobin and hemoglobin. The most common trigger for AKI in the inpatient population is sepsis, and other common reasons include major surgery and acute decompensated heart failure. The kidney is able to maintain GFR even in the face of changing arterial pressure and volume status. And reduced MAP, it initiates a series of systemic and local processes. The sympathetic system, it is activated, ADH is released, and the renin-angiotensin aldosterone system, it increases the angiotensin 2 activity. The net result is water retention, increased sodium absorption, and preservation of GFR. Later, if the hypoperfusion is not corrected, angiotensin 2 is eventually it causes vasoconstriction of both the afferent and the efferent arterioles, and as a consequence, it reduces the GFR. So these mechanisms function only as long as the MAP is maintained above the autoregulatory threshold. Below a MAP of 75 to 80 mmHg, the autoregulatory efficiency, it declines abruptly. So, a wider and more complex understanding of the mechanisms of AKI are emerging, and the simple ischemia model, it alone, it cannot explain the sepsis and major surgery-associated AKI. Hemodynamics in sepsis are dominated by a hyperdynamic state, and global renal blood flow may remain intact. And decreased perfusion, it might not be the only reason for major surgery associated AKI, because even prolonged periods of partial occlusion of renal artery are well tolerated. And evidence suggests that systemic inflammation leading to tubular injury is responsible for sepsis associated AKI, whether or not the ischemia was the initiating factor. Apart from the general mechanisms that are common to the AKI from various causes, other specific contributions to the perioperative AKI are of special note in the surgical patient, like the comorbidities. So these patients suffer from comorbidities like CKD, metabolic syndrome, diabetes, cardiovascular and hepatobiliary disease, all of which are well-documented risk factors predisposing to AKI. Even male sex is an risk factor for AKI. And other reported risk factors include functional dependence, ventilator dependence, COPD, smoking, bleeding disorders, patients on chronic steroid use, and even cancer patients. So a retrospective cohort study, it evaluated the incidence of AKI in patients admitted to the ICU of the PSU, and independent risk factors of AKI include ASA physical status, revised cardiac risk index, high risk surgery, and congestive heart failure. And prospective cohort study conducted in non-vascular, non-cardiac surgery patients. They identified age, diabetes, revised cardiac risk index, and ASA status as an independent risk factor for AKI. Coming to obesity, obesity is also a risk factor for AKI, and it is associated with metabolic syndrome and can alter the renal hemodynamics. The special characteristics in obesity are obesity-related glomerulopathy, which include the changes in GFR and glomerulomegaly. And recently, this study was done on ICU trauma patients, and it showed that AKI was correlated with abdominal fat in particular as measured by CT. So higher BMI is associated with increased risk of AKI after major trauma, and they evaluated with the use of CT in this study. Coming to the surgery, like in every major surgery, a risk for reduction in effective blood volume or mechanical obstruction, it exists. And hypovolemia, low systemic vascular resistance because of anesthesia or iotocaval compression, and direct injury to the renal system are all common events during surgery that can harm the kidney. And emergency surgery is also a risk factor for AKI, and patients presenting with sepsis to the OR are at an increased risk for AKI. And major vascular surgery, cardiac surgery in particular, are also well-known factors for AKI. And patients undergoing laparotomies, intraperitoneal surgeries, and small bowel resections are also more more prone to develop AKI. And lung resection has a relatively high incidence, and an observational study on cardiac surgery, because of infective endocarditis, it showed the incidence of post-op AKI to be as high as 59%. And increased intra-abdominal pressure is also common in ICU patients after abdominal surgery, and it can be frequently explained by excessive administration of fluids, can cause abdominal compartment syndrome, can mechanically compress the renal veins, and it can even constrict the renal arteries via activation of the sympathetic system. So increased intra-abdominal pressure, it can ultimately lead to reduced renal perfusion and create an ischemic insult to the kidney and cause AKI. And laparoscopy can also lead to transient increase in the intra-abdominal pressure. And as a result, during laparoscopy, the recorded urine output is significantly reduced. And the patients can become oliguric despite normovolemia and normotension. And several studies have shown that the observed reduction in urine output during laparoscopy, it is not at all predictive of the postoperative AKI in adults and even in children. And in the critically ill and in patients suffering from CKD, the duration of pneumoperitoneum should be minimized. Coming to the anesthetic agents, the anesthetist, as we all know, he can influence the risk of AKI in several ways, like hemodynamic management, in particular keeping the MAP above 55 millimeters of mercury and maintenance of euvolemia. They all prevent the occurrence of perioperative AKI. And historically, like some halogenated anesthetics were considered nephrotoxic, like methoxyfluorine, which are no longer in routine use. And use of sevoflurane is associated with increased plasma fluoride concentrations, and it produces a haloalkene called compound A. However, it has been evaluated extensively and is considered safe to use. And regarding the choice of anesthetic technique, most reports they concern the beneficial effects of inhaled anesthetics and propofol to attenuate AKI in the experimental studies. And recently, a study conducted on 112 patients undergoing valvular heart surgery and randomized to anesthesia by either propofol or sevoflurane. It showed that anesthesia with propofol is associated with a reduced incidence and severity of AKI. And another study on the healthy volunteers, it found that sympathetic block caused by the epidural anesthesia, it did not change the renal blood flow significantly. Meta-analysis found the incidence of AKI to be lower for neuraxial anesthesia when compared with general anesthesia. Also, another study, it evaluated epidural anesthesia combined with GA in cardiac surgery, and it found reduction in AKI in the combined group. And also one more study, it combined GA and neuraxial anesthesia to have a similar incidence of AKI when compared with GA alone. Coming to cardiac surgery, the incidence of AKI, it can reach around 30% depending on the definition of AKI. The mechanisms of cardiac surgery associated AKI are multifactorial, and they mostly are based on the use of cardiopulmonary bypass. And some of the pathophysiological explanations are ischemia reperfusion injury, microembolization, inflammation, decreased renal perfusion pressure, hemodilution, and use of nephrotoxic drugs. Pre-op CKD is also an important risk factor for perioperative AKI, especially in patients with cardiac surgery. And other risk factors are age, female gender, pre-op anemia, PRBC transfusions, heart failure, emergency surgery, diabetes, hemodilution on CPB, duration of CPB, and use of an IABP, and valvular surgeries. Methods to prevent cardiac surgery associated AKI, they have been reported with varying degrees of evidence. Like pre-op methods, they include the use of aspirin, avoiding diuretics, maintaining euvolemia, avoiding anemia, use of erythropoietin, and use of prophylactic renal replacement therapy. And intra-op methods, they include again avoiding anemia and PRBC transfusion, maintaining MAP above the cerebral perfusion pressure, pulsatile perfusion during the use of cardiopulmonary bypass, preferring off-pump CABGs, use of intra-aortic filtration, and use of a miniature CPV. So the main post-operative strategy is the early use of renal replacement therapy. And apart from this, some pharmacological protective agents have been proposed, like phenoldopam, statins, human atrial natriuretic peptide, and nesiritide, but there is no conclusive evidence to support their use. And recently, remote ischemic preconditioning was also shown to reduce the incidence of cardiac surgery associated AKI and the need for renal replacement therapy in high-risk patients. Coming to pediatric surgery, the data on pediatric perioperative AKI is very limited. Although the neonatal period is relatively short, the AKI burden is disproportionately high in this age group. And the most common cause in neonates and infants is post-cardiac surgery AKI. And pediatric AKI is almost defined in a similar way to adult AKI, but with some modifications, with the exception of the first few days of life when the neonate's creatinine, it reflects the mother's serum creatinine. And later neonatal GFR, it is correlated with gestational age and postnatal age in the preterm neonates. And high vigilance is necessary in the pediatric population, especially in children who are admitted to the ICU. And cardiac surgery associated AKI in children, it has many risk factors, but the two consistent ones are prolonged use of cardiopulmonary bypass and younger age. And currently, the early management of pediatric AKI, it involves identification of patients at risk, optimizing the volume status, and administering theophylline for neonates suffering from severe asphyxia. Coming to transplantation surgery, it is usually a complex procedure and usually involves high-risk patients, and AKI further complicates many of these procedures. And transplanted kidneys are more susceptible to surgical, ischemic, and drug-related insults, predisposing them to AKI. However, this application of regular definitions of AKI to a transplanted kidney, it is more problematic considering the postoperative changes in serum creatinine concentrations. So it is not always possible to differentiate between perioperative AKI and graft dysfunction. And coming to liver transplantation, the effects of cirrhosis, nephrotoxicity of some immunosuppressive drugs, and the risks of surgery are also well-known risk factors for periop AKI. The incidence of post LT related AKI, it varies from 14 to 78% depending on the definition of AKI, type of transplantation, and the patients included in the study. However, this LT related AKI, they have specific diagnostic problems which are attributable to high bilirubin concentrations, muscle wasting, edema, and post-op use of GFR lowering medications like tacrolimus. All of these can affect the creatinine concentrations and under or overestimate the incidence of AKI. While some risk factors for liver transplant related AKI are similar to other high risk surgeries, some risk factors are unique. So, accordingly, strategies to prevent the LT related AKI, they include the use of terlipressin and avoiding or lowering the dose of tacrolimus after surgery. A small scale study, it found, which was performed on the lung transplant patients, it found out the incidence of AKI post lung transplantation to be around 54%. And the incidence of AKI among patients who had a double lung transplant was almost double, like 87%. And the incidence in one lung transplant patient was 40%. And in all the patients who have acquired AKI, intraoperative hypoxemia was correlated with AKI. Coming to the drugs, nephrotoxic drugs are a well-established cause of AKI of pre-renal, post-renal, and even intrinsic origin. And nephrotoxic drugs are they almost involved for in up to 25% of the critically ill patients causing AKI. And large population-based study, it showed that the combination of more than two prevalent nephrotoxic drugs, diuretics with angiotensin receptor blockers or ACE inhibitors and NSAIDs, they increase the risk of AKI. ACE inhibitors and NSAIDs in particular, they may worsen the pre-renal AKI because of their influence on compensatory mechanisms aimed to maintain the GFR. And aminoglycoside, which is a commonly administered antibiotic in the OT, they can also cause AKI through intracellular processes such as mitochondrial dysfunction and reduction of protein synthesis. A high dose of aminoglycoside, CKD, hypovolemia, diabetes, and old age are all risk factors for aminoglycoside-induced nephrotoxicity. Coming to contrast-induced AKI, so it is a subtype of drug-induced AKI with well-defined characteristics. The pathophysiology is a combination of both hypoxic and toxic damage and endothelial dysfunction. And contrast dye-induced AKI, it can be prevented by maintaining normovolemia, augmenting urine output, and withholding other nephrotoxic agents. And other strategies include the administration of sodium bicarbonate and N-acetylcysteine, although evidence is not well established for these treatments. So patients with hypovolemia are at increased risk of contrast dye-induced AKI, and maintaining the effective blood volume is essential before exposing the patient to the risks of drugs and contrast dyes. So, a summary of possible insults predisposing to the AKI in this perioperative period is tabulated in this one. So, like discuss all of these we have discussed now, and pre-renal things preoperatively, the etiologies include the predominantly losses, hemorrhage, third spacing, sepsis, cardiac failure, increased intra-abdominal pressure, cirrhosis, hepatorenal syndrome, and intraoperatively also hypovolemia and losses, hypotension due to low systemic vascular resistance, which might be even anesthesia induced, low cardiac output, increased intra-abdominal pressure, and aortic cross-clamp. And drugs like we have discussed, NSAIDs, ACE inhibitors, norepinephrine, and even diuretics. And perioperatively, inflammation, patient comorbidities like CKD, diabetes, obesity, and drug-induced like antibiotics, aspirin, diuretics, clopidogrel, tacrolimus, radiocontrast agents, endogenous nephrotoxins, acidosis, infection, use of a cardiopulmonary bypass, anemia, packed cell transfusions, like fluid solutions like hydroxyethyl starch, and post-renal are preoperatively, if the patient has tumor or prostatic enlargement, presence of calculi, blood clots, or a neurogenic bladder, and intraoperatively if there is a damage during any surgical intervention. So, coming to the perioperative management, the first step in preventing and treating the AKI is to identify the patient's at risks. So, like we have discussed earlier, extremes of age, comorbidities, anemia, potential hypovolemia, contrast dyes, drugs, and emergency surgeries, they should all alert the anesthetist to the possibility of an AKI, and that is perioperative AKI. And so, because some of these risk factors can be optimized before the surgery. And the first thing is the hemodynamic goals. The main hemodynamic goal in the perioperative patient is to prevent tissue hypoperfusion and thus organ hypoxia. And direct monitoring of tissue hypoxia is not readily feasible in the clinical setting. Thus, indirect measures like mean arterial pressure, heart rate variability, and lactate concentrations are usually used. And in the ICU setup, MAP more than 60 to 65 mm of Hg is recommended to prevent the AKI. And a meta-analysis, it showed that perioperative hemodynamic optimization is required to reduce the postoperative AKI. And this study, it is a retrospective cohort study. It was conducted on more than 5,000 patients undergoing non-cardiac surgery. It found out the similar results, and the risk of AKI was increased when MAP was less than 60 mm of Hg for more than 20 minutes, or less than when the MAP was less than 55 mm Hg for more than even 10 minutes, the patient landed up in AKI. And these large-scale studies, they aid us in determining a MAP threshold to be maintained during the surgery. And they also emphasize the importance of duration of hypotension, because even short periods of hypotension, they have been shown to affect the kidney. And given that autoregulation changes along with comorbidities, so all of the patients should not be considered equally, and baseline MAP and everything should be considered, and we should possibly adopt a more personalized approach to intraoperative arterial blood pressure management. Coming to the choice of fluid solution, use of 0.9% saline, it is associated with the development of hyperchloremia. And several human experiments, they suggested that saline infusion is correlated with reduced renal blood flow compared with balanced solutions. And in a large study in the ICU, chloride restricted fluid management was associated with less AKI, and sorry. So it was associated with less AKI and renal replacement therapy, and similar results were observed in liver transplant patients where chloride liberal fluid administration was a risk factor for post-op AKI. And this the association of colloid solutions with AKI is controversial, and several recent studies, they reported an increase in the incidence of AKI and renal replacement therapy in the critically ill patients who have been infused with hydroxyethyl starch rather than the crystalloids. And these studies, they evaluated that hydroxyethyl starch solutions with different molecular weights, including the low molecular weight solutions. And to date, intraoperative use of HES solutions is not recommended in patients with AKI or who have been at risk for AKI. And in a recent paper, this Hartog and colleagues, they raised the concerns regarding the intraoperative use of HES and concluded that in the absence of a proven benefit and considering the methodological problems with studies supporting the use of hydroxyethyl starch, they do not recommend the use of hydroxyethyl starch solutions in any clinical situation. Coming to the intraoperative fluid management, so appropriate hydration is considered important for the avoidance of AKI, and intraoperative urine output is often monitored, but it rarely responds to fluid administration. And infusion of crystalloids, it showed a reduced clearance and slower distribution. So intraoperative oliguria, it may not reflect the fluid status or predict the future AKI. So in it is a retrospective study in non-cardiac surgical patients that evaluated the risk factors associated with AKI, and it did not find that oliguria to be predictive of post-operative AKI. And two prospective randomized studies that involved bariatric patients and patients undergoing thoracoscopic surgery for lung resection, it found out no correlation between intraoperative urine output and post-operative AKI. And in both the studies, intraoperative oliguria was not predictive of post-operative AKI. And additionally, both studies, they found out that no relationship between the amount of intraoperative fluids administered and intraoperative urine output or post-operative renal dysfunction was there. And given that liberal fluid administration can be correlated with worse post-operative outcome, the recommendation to maintain urine output of at least 0.5 ml per kg per hour, it should be reconsidered. And urine output in anesthetized patients may not be an adequate indicator of fluid balance and is not predictive of post-operative AKI in the elective surgeries. And coming to the use of diuretics, loop diuretics and mannitol, most of us commonly use during surgery in an attempt to prevent the AKI or treat oliguria or anuria based on experimental studies. And this practice has not been shown to be beneficial. And on the contrary, use of diuretics can be harmful because these agents can cause prerenal damage and nephrotoxicity, and diuretics are not recommended except to treat volume overload. So these are just two of the many studies that have been done, and diuretics have been shown to be ineffective in the prevention of AKI or for improving income outcomes once the AKI occurs. And coming to anemia and the use of blood products, a large observational study which involved non-cardiac surgery patients, it found out that preoperative anemia and early post-op decrements of hemoglobin, they are associated with AKI. And pre-op anemia and perioperative PRBC transfusions, they are the risk factors for AKI in cardiac surgery. So according to proportion, every unit of transfused blood in cardiac surgery, it increases the incidence of cardiac surgery associated AKI by 10 to 20%. And additionally, stored PRBCs can cause organ damage and are associated with reduced oxygen carrying capacity. It is therefore advisable to optimize patients' pre-op hemoglobin status while using the necessary measures during surgery to reduce the blood loss and avoid unnecessary PRBC transfusions. Coming to use of vasopressors, norepinephrine, it constricts the renal arterioles and reduces the renal blood flow, but it is commonly used and is considered safe and effective. And vasopressin, in addition to the norepinephrine, it did not show any clinical benefit. And low dose dopamine, it can enhance the urine output through its diuretic effect, but is no longer considered renoprotective and is not recommended for the treatment of AKI. And compared with norepinephrine, dopamine is associated with more adverse events, and phenylephrine, being a potent vasoconstrictor but with a profound alpha adrenergic activity, it also causes vasoconstriction. So the current KDIGO guidelines, they state that so far no vasoactive agent is superior than the other. Coming to vasodilator therapy, the current recommendations are against the use of vasodilators therapy in the prevention or treatment of AKI. So, concluding this session, perioperative AKI, it continues to be a feared consequence of surgery, and it is associated with both short and long-term side effects. And the complexity of perioperative AKI pathophysiology, it involves the combined roles of ischemia and inflammation, and novel biomarkers are proposed as a faster and more accurate way for prompt identification and could prove beneficial in the early future. And specific comorbidities, surgeries, and interventions, they increase the risk of AKI, such as cardiac or transplant surgery and use of contrast dyes. And the intraoperative period is unique in both anesthesia and surgery, have to be combined to affect the renal function. And during surgery, even short periods of hypotension, they put the kidney at risk. And urine output, it does not predict the postoperative AKI, and careful selection and use of IV fluids and vasopressors and appropriate blood management are important to prevent the perioperative AKI.
Nice class, Arvind. Yeah, now it's open for discussion. Anyone wants to have inputs, added points?
చాలా బాగుంది శ్రీకాంత్. అంటే ప్రిసైజ్ గా అన్ని పాయింట్స్ చెప్పాడు, కవర్ చేసింది. ఓన్లీ థింగ్ ఇస్ క్లియర్లీ సెడ్ దట్ రియల్ ఫెయిల్యూర్ ఇస్ నాట్ ఈజీ థింగ్ అండ్ ఈజీ టు ఐడెంటిఫై and preventable. Most of the times it's preventable. LASIX is going to be not a good thing. This is the pain points, I think. Am I right?
Yes, sir. Yes, absolutely.
Thank you.
Yes, so that's very important points. Actually, our reach for diuretics should come down. Even this day, so many people, I'm still surprised to find some of the consultants speaking about the use of diuretics in the immediate postoperative period, and also that renoprotective effect of the low dose dopamine. Even to this day, most of them speak about the benefits of them. And the most important things I consider is we have to divide this into three categories. So main is previously, like preoperatively normal patient landing into ARF, or a patient who is already in acute renal failure, we are proceeding for surgery. And the third category of patient is a CKD patient. Either it can be acute and chronic CKD, or we have to take care of not adding an acute insult to the CKD patient. These three categories we have to categorize the fluid management and how to proceed with the case and all.
Yes.
మోస్ట్ ఆఫ్ కన్సల్టెంట్స్ ట్రైనింగ్ అయినప్పుడు ఏది ఉందో అది దే బ్లైండ్లీ ఫాలో అయిపోతుంటారు కదా.
Yeah, sir.
సో వాళ్ళు ఇప్పుడు ఫ్రెష్గా చేయాలంటే వాళ్ళు టీచ్ అన్న చేయాలి, లేదంటే వాళ్ళ దగ్గర సంథింగ్ దే హ్యావ్ టు గెట్ ద పాయింట్ ఫ్రమ్ దేర్ బాస్.
And this regional versus general for renal failure, what do you suggest, Arvind, based on all the studies and all?
అది అంటే మల్టిపుల్ స్టడీస్ మల్టిపుల్ ఇవి చెప్తున్నారు సార్. సో కంబైన్డ్ అంటే కొన్ని స్టడీస్ లో కంబైన్డ్ జనరల్ అండ్ న్యూరాక్సియల్ దే హ్యావ్ ఎ సిమిలర్ ఇన్సిడెన్స్ ఆఫ్ ఏకే అని అంటున్నారు కంపేర్డ్ విత్ జిఏ అలోన్. అండ్ కొన్ని వాటిలోని ఎపిడ్యూరల్ కంబైన్డ్ విత్ జిఏ ఇట్ ఫౌండ్ రిడక్షన్ ఇన్ ఏకేఐ ఇన్ ది కంబైన్డ్ గ్రూప్ అని అంటున్నారు. అంటే మల్టిపుల్ స్టడీస్ దే హ్యావ్ మల్టిపుల్ అవుట్పుట్ సార్. సో వి కాంట్ అంటే
about like suppose spinal versus epidural and complete regional versus GA. What's your preference?
Definitely regional would be superior, I guess, sir.
Actually, the earlier thought used to be in sick cases, or at least in renal failure cases, when spinal compared to epidural, and if you want to give based on peripheral setup and all, if you are decided on giving regional, they used to say epidural is better than spinal.
Yes, sir.
Because sudden hypotension would not be there like in spinal and all. Yes, and sir. Then when the facilities are there, you are working in a good hospital like that. So they say whenever there is a renal failure, GA is better because you can maintain hemodynamics more
under our control,
than in regional. It's really true. I mean, like I'm asking, like not only you, but all the practicing. Sorry, like what is your preference when this call has to be taken, spinal versus epidural, if you want to go with regional, and regional versus GA when the facilities are available in renal failure patients? What's your take on this?
Sir, if I was in OT, I would have definitely gone for GA, sir. In even if I had a small doubt, also I would always go with GA. But these studies and all, they even I mentioned earlier, like one meta-analysis study, they found the incidence of AKI to be lower for neuraxial anesthesia when compared with GA. So apart from this studies, I don't know. I'd like the seniors to comment on this.
Anyone else want to? So this Kiran
సిస్టర్ కంప్లీట్ సజెస్ట్ చేయాలి.
Sir,
సిస్టర్ కంప్లీట్ చేయాలి.
Sir, actually, when Arvind was talking in the class about neuraxial anesthesia for ARF patients, the study that was mentioned there was published in British Medical Journal in 2000. So it is actually a study of not just renal failure, it's an overall mortality study. So it is published in British Medical Journal in 2000. So the study encompasses a period before 1997. So up till Jan 1997, they have done, and this particular study has taken into consideration around 141 trials, which is a very big study. 141 trials, including 9,559 patients. So we forget about all the methodology and all, and we jump to conclusion. The conclusion given in that study, which was published in BMJ, is neuraxial blockade reduces postoperative mortality and other serious complications. The size of some of these benefits remain uncertain, and further research is required to determine whether the effects are due solely to the benefits of neuraxial blockade or partly due to avoidance of general anesthesia. Nevertheless, these findings support more widespread use of neuraxial blockade. So this was in 2000. somewhere 22 years back.
22, yeah. Retrospective study.
Yeah, the retrospective study, they included all the trials before 1997. So this is dating back to somewhere 30 years back concept. So even for 30 years, they say neuraxial blockade is better than, yeah, because in the conclusion also, they are clearly, they have mentioned that they don't know how the effects are, I mean, like what's the exact cause of these effects, but more than the benefits of neuraxial blockade, they are thinking or maybe they arrived at a conclusion that it is mostly due to avoidance of general anesthesia in these cases.
Yes, sir. Yes.
But one point I want to say at that time, but maintenance of blood pressure is better with the GA or regional?
So this concept of sudden hemodynamic drop with spinal is much longer debated, sir. Actually, previously in PAH cases and while conducting LSC also they used to say definitely epidural, no spinal. And later on they changed it to spinal anesthesia as the choice of anesthesia in PAH. So maybe more and more evidence or more and more safe practice of anesthesia may be allowed for regional anesthesia to be conducted more safely nowadays, I think, or better drugs.
Particularly in UK, I heard that nobody uses, everybody will go for GA, not for regional. Any reason?
So when I see the main problem, I mean, I don't know exactly, but this is my hypothesis. So the most what we see or control of hemodynamics during general anesthesia. So whatever we talk about control of hemodynamics, it happens once the patient is induced, and then you can control all things. But controlling the pressure response during intubation and extubation is very difficult even to this day. Maybe in UK with the more usage of LMAs, maybe the pressure that may be the contributing factor for less of advancements there. That is my thought. Not sure.
Hello.
Madam, you are the better judge.
Say, I'm not discussing about why they prefer GA and ECADO. I think usually there the patients are explained about both the regional GA and they ask so many questions. So eventually they decide what they want. And when they definitely say, I want this, you have to go with that. And for risk patients, they get explained about benefits of regional. So many times they get convinced and go for regional, but still they would like to have some sedation or LMA something, so they don't want to know what's happening to them. So many patients ask like that. So probably that's the cause. Many times they get both GA and epidural for major surgeries, not just one epidural. So that's one thing. And regarding AK, I think, as you said, epidural doesn't cause sudden drop in blood pressure and hemodynamic changes suddenly. So maintain with vasodilatation, it maintains renal perfusion. Whatever they are saying about reduced incidence of AKI is mainly due to maintaining good renal perfusion. That's the cause why regionals cause less AKI. Most likely that's the reasoning behind it. But once you give both regional and GA, if it is lighter planes, that's okay. You don't drop BP much. But if you give if you have to have infusion of propofol or something, and then GA and epidural, you may most probably cause lot of vasodilatation, drop in blood pressure. Then you end up using either phenylephrine or nor to maintain blood pressure. That's not good for kidneys. Then you're obviously reducing the renal perfusion. That's another cause why you want only epidural rather than including GA. But many times lighter planes of GA with epidural may benefit because they don't want to know what's happening, and they can sleep and as well get the benefit of regional and maintain perfusion. So I feel that's the reason. But if they have severe cardiac problems, anything, obviously we go for GA that to maintain hemodynamics, as we can't control once the regional is given. We don't know individual response, how they behave after giving even small doses or titrated doses of epidural. We don't know how one responds. So that's what I feel. Maybe that's the study. And as you said, they mainly concentrated on mortality, morbidity, and AKI all together rather than just sticking to AKI comparison, I feel. Thank you.
Thank you, madam. Any further inputs? Onkar, Chandana, Mehta ji, sir. ఓంకార్ కేసులో బిజీగా ఉన్నట్టున్నాడు పైన.
చాలా బిజీగా ఉన్నట్టుంది.
యాక్చువల్లీ కొంచెం ఎక్కువ ఉన్నాయి, వరుసగా ఉన్నట్టు ఉన్నాయి. విక్రమ్ దయ్యండిలు అవి ఉన్నాయి. And as a few of the important points like intraoperative urinary output should not be considered. Use of aminoglycosides in the postoperative period. These things generally the common things we should actually take into consideration. So I like that part. And the tables are very good. Dividing into perioperative, intraoperative, and all.
Yes.
So I think you shared the PPT in the group. It's very informative PPT, that one.
Sure, sir. Definitely. Thank you for sharing these articles.
Thank you. Nice class, Arvind.
Thank you,
Bye.
ma'am.
Bye.
Thank you, madam.
Bye.
Thank
Bye. Okay, sir, we can conclude then. Yeah.
Meet next week. Thank you so much.
Thank
Bye-bye.
you. Thank you, everyone.